Now, we are listening to the next speaker is current evidence of bone substitute for traumatic bone loss, which is, again, very interesting subject because sometimes when I saw the x-ray, I don't understand why they put bone substitute in the fracture. Please, go ahead.
Let's start. My topic is about the current evidence of bone substitute for traumatic bone loss. Today, we just a little bit talk about the bone graft classification and property, and then we go to the current evidence of the each commonly used bone graft in nowadays in trauma. You all know that the fundamental property of the bone graft has to consist of the osteoconductive, inductive, and osteogenesis. And nowadays, the gold standard should be the autologous bone graft, and an indication of the bone graft is related to the structural augmentation, the critical site bone defect, and fracture non-union using for the carry material like antibiotics and for bone ingrowth and on-growth like in prosthesis. We can see that the bone graft can be classified in different types based on the substrate or material used for the bone graft, such as allograft, growth factor, cell-based, and ceramic-based, and polymer-based. Today, I focus on three types that which we are commonly used as allograft, growth factor, and cell-based. And review by open review. They have many types of graft. I only put something that show in this table, and you can see that in allograft that the problem of allograft is limited to the cost and the harvested, and there is the limited osteoconduction and infection risk. So we move on to use derived bone matrix in nowadays and combine with the graft. And for the growth factor base, we have the bone morphin protein or BMP and platelet plasma, and for the ceramic base, we nowadays use mostly on the high hepatitis, which has the limited osteoconductive. First, about the allograft. The allograft limitation is based on if you consider to use the allograft is a big site, there is the problem about the longer incorporation period, and there is the problem that healing that the inner side of the part of allograft may not be healed, and bone strength will be weakened at 6 months, and then come back to more strength at 1 or 2 years. And when we use about a massive allograft, there is complication risk about this graft, such as the non-union and fracture or surgical site infection. Moreover, the infection risk related to allograft is the transmitted disease, which is rare but sometimes serious, such as HIV infection, hepatitis B, hepatitis C, and some bacteria. And according to the literature review, that the infection related to the sterilization method that most of we commonly use is related to freezing and freeze drying. However, some sterilization methods carry the risk of the contaminated, such as the gas will not penetrate the cortical bone, and radiation cannot destroy retrovirus. For demineralized bone matrix, the literature review, like a systematic review, I think the most updated is end on the 2017. And you can see that even we have many types of DBM in the market. Some use that DBM in the trauma surgery, but the study related to DBM is mostly only level 3 and 4. Moreover, when you consider the DBM characteristic in the market, you can see that the DBM percentage in each market available is different, like 40% here and some down to 17%. And there is a difference in the carrier material in the DBM also. So right now, the data for the DBM is indication for just bone graft extender for trauma surgery. You have to mix it with something like an allograft, autograft, or bone substitute, other type. Next is related to growth factor base. I will start first with a platelet-rich plasma. You can see that when you concentrate the platelet, the growth factor and cytokine in platelet concentrate will be available as much like this, and therefore there is many meta-analysis before 2022 that show that PRP is help for the fracture healing. However, in 2023, there is an umbrella analysis that try to check the quality of the PRP for fracture healing. At first, when we look for the pool analysis from the meta-analysis, 5 meta-analysis before, we can see that the fracture healing time and healing rate for PRP is significantly better with the PRP. However, when we analyze each original study, we can see that there is a significant heterogeneity of the study that related to study type, dose, and duration of treatment, type of bone used, and sample size, and the population. So they tried to reanalyze the PRP original study again and found that the healing rate of the PRP study is not significant. However, the healing time from PRP is significantly better compared to the control. Therefore, the result that for now is the PRP help for healing time but not healing rate. Next one is related to bone morphogenic protein. You can see that this one is the potent osteoinductive factor that can work through the cells in at least 2 pathways and can be applied in many ways with different carrier. But right now, because of the cost, the clinical indication of BMP is approved only for open and non-union fracture, vertebral fusion, and maxillofacial bone enhancement, which has the 2 types of BMP available in the market. For compare with autologous bone graft, the systemic review and meta-analysis from 2023 indicate that there is the total of 14 studies and there is no significant difference between BMP and autologous bone graft in terms of healing and healing time. However, when you do the subgroup analysis, they show that there is BMP has a higher healing rate and shorter healing time in subgroup analysis of the moderate quality. Like this, the study is 14 study. You can see there is both of BMP7 and BMP2. When you try to check about the efficacy of BMP2 and BMP7, there is one study in 2018 that tried to compare the BMP2 and BMP7, and this study showed that the BMP2 has efficacy higher than BMP7 with the success rate or ratio that 22.7. And when you consider about the way to use in the non-union, you can see that the infected non-union has a higher success rate than the aseptic non-union, which means that the BMP is highly likely to have success in infected non-union. However, they still have the negative risk factor for the BMP use, like smoking, atrophic non-union, and high bone weight and larger defect size from this study. Nowadays, we move on to use the BMP2 with autograft and Professor JKO that try to do the study with BMP2 and show that with the single prospective cohort study, they have the success rate is very interesting in 1 year, like 100% in 23 patients, non-union with fracture-related infection, like in this case. They do emasculate first and then put the BMP2 with the autograft and show the successful healing in 1 year. But for now, because you know that the bone graft substitute have been designed in different way, so recently Professor Genodis tried to make a concept of the polytherapy that try to combine different type of graft and call it composite graft. Like in this case, that use both autograft, allograft, xenograft, and BMP and bone marrow aspirate to use and also show that successful. However, there is also limited evidence for using composite graft until now. For ceramic base, like healthy appetite, you know that there is used for a long time and have different types of the ceramic base. Because of different type, you can see that they have the different composition and different of the biodegradability of each graft. If we focus on the healthy appetite, we can see that there is the limited of osteoinductive in the hydroxy apatite, and there is the show from the basic study that there is less bone formation or no detectable bone formation in three months. So now they try to develop a new or next generation of synthetic bone graft. Until now, there is the science that using the new technology like a nanoparticle that try to invent like a nanoparticle of the hydroxyapatite and found that the successful of the stimulation of the osteoinductive property. So nowadays, the synthetic bone graft try to move forward to the new generation that use the combine of the osteoinductive material and the osteoconductive material that has invent for the nanotechnology and show that in vivo test is successful and have the comparable efficacy with the autograft. But I'll not talk about this until now because the study is still limited. So my summary is for now, the gold standard still be the autograft. And when you try to use the autograft, you have to be careful about the longer incorporation period and have the specific complication related to massive autograft. The commercially available bone substitute like an DBM has an indication for the only bone graft extender. You have to mix with the other type of graft such as the autograft or allograft. For PRP, the evidence show that there has the potential to decrease the healing time, but not the healing rate. BMP has a successful result with BMP2 more than BMP7, but it still needs time to convince that the BMP can help for different type of fracture problem, like a non-union and together with the musculoskeletal. Ceramic base, like a hydroxyapatite, has limited osteoconductive efficacy. However, new kind of synthetic graft is coming now, so we have to look for that. And composite graft with the concept of the polytherapy, with using many types of grafts such as autograft, allograft, and DBM and bone marrow aspirate is coming and promising for result. Thank you.